Hello, and welcome to If These Wheels Could Talk, presented by Melissa Wheeler, Director of Disparities and Outreach at Atrium Health, and Darcy Dagey, Clinical Supervisor of Lung Bases for Life at Atrium Health. This webinar will review the Mobile Lungs Cancer Screening and Outreach Program at Atrium Health and provide details and insights about the results and management of the program. My name is James Sheehan, Digital Brand Manager of Mobile Computed Tomography at Neurologica, a subsidiary of Samsung Electronics. This webinar is a follow-up to a symposium that we held in 2019 in Minneapolis, and that we hope to continue these great discussions in person in 2022. A quick background on how Neurologica became involved in this project. It was in late 2015 when we first met Melissa and Darcy to talk about their need for a truly mobile vehicle platform with a full body CT scanner on board for low dose lung cancer screening. It was a great opportunity to work on a first of its kind vehicle that can move from place to place easily, but it was also a project which we felt we were uniquely positioned to work on, having experience placing our smaller head scanners onto ambulances for stroke triage for several years by that point. Since 2015, as we have followed the wonderful outreach work and the innovation of the Lung Bases for Life program, it has also driven several internal innovations on the imaging and manufacturing side for us. We have built 2 vehicles for Atrium Health, with the latest being through a partnership with Winnebago and Summit Bodyworks. This vehicle in particular is about the same size as a blood donation bus. It features several spaces for patient onboarding, patient waiting, a technologist room, and the scan suite, and has a full network of Winnebago for servicing. The BodyTime Elite, which is on board both of their vehicles, is a 32-slice mobile CT scanner with an 85-centimeter gantry. It runs independently and even scans utilizing internal batteries, which is unique to our CT systems. It is also internally lead shielded. Some of the new features which we developed specifically for Atrium Health and which are now offered on all of our BodyTime Elite systems include low-dose scan protocols for lungs and online noise reduction. Our first speaker today is Melissa Wheeler. She's been with Atrium Health for 12 years. And is the Director of Disparities and Outreach.
Thanks for the kind introduction, James, and welcome everybody virtually to North Carolina. It's a little humid here today, so it's a bad hair day for some of us. We really look forward to sharing just some highlights of our program, how it came to be, talk a little about the patients that we serve, some of the challenges that we've encountered along the way. But I'm going to start off with giving you just a little bit of background on our healthcare system, on our Cancer Institute, and the outreach work that we do. So Levine Cancer Institute is a part of Atrium Health, and Atrium Health was formerly known as Carolina's healthcare system. It's the 3rd largest not-for-profit healthcare system in the country, 900 different locations. Levine Cancer came to be back in 2011 when Dr. Derek Ragovan joined the team as the president of our Cancer Institute, and decided at that point that he really wanted to create a decentralized model of care for our region. And by decentralized, what I mean is basically everything that you can find at our Moorhead location, which you're looking at in the heart of Charlotte. All of the services we can provide to patients here, we can also provide to patients in the rural areas of North and South Carolina where we serve patients. We currently have 25 different Levine Cancer Institute locations across North and South Carolina. And we see about 19,000 new patients per year. Back when we started in 2011, we only saw about 4,000 patients a year. So we've grown just a little bit in that period of time. We are a Plaintree accredited institution, and what Plaintree really is it's an international organization that focuses on patient-centered care. And so as we talk a little bit more about our outreach and the programs that we have, you'll understand how much that means and how important that is into the delivery model that we have here at the Cancer Institute. Our outreach approach, again, goes back to that patient-centered care. So we're really responsible for 3 primary buckets: cancer prevention education, cancer screening programs, and the development of community partnerships. And throughout all 3 buckets, we have care coordination. So none of these programs stand in isolation from each other. In fact, typically all three kind of cross over the lines with each other. When we started the program, the Disparities in Outreach program, about 7 years ago, we only had breast screening in one city and one location in Charlotte. We are now in about 21 different counties with all of our cancer education programming, our screenings, and our community partnerships. We have about 300 different community partners that we work with. And our community partners support everything from locations for us to host our screenings, places for us to park our bus, to providing referrals to our programming. They might also serve as primary care for some of our patients that we identify in our rural areas. About 70% of the patients that we serve are not actually Atrium Health patients. They are patients that are uninsured and underinsured out in the community, out in the rural areas. So where Charlotte is very metropolitan, the majority of what we're serving is outside that metro area, where there is low health literacy, difficulty accessing care, whether it be primary care, especially specialty care. We have a lot of financial barriers, transportation barriers, and issues of the like. So it was really important to us as we started building programming for these vulnerable populations that we really took a hard look at, are we just going to educate and screen, or are we really going to provide whole patient care? And to us, it was very, very important that regardless of what type of screening we were doing, that whole patient-centered care was key. So when our patients come forward, whether it's for education or screening, we really do a full patient assessment. We ask questions like, do you have primary care? Do you have a safe place to live? Are you able to get transportation to your doctor's appointments? Do you have medical bills that are prohibiting you from getting the care that you need? And so the position on our team that does that is a cancer program development specialist. And when a patient reports a barrier to care, then our cancer program development specialists literally pick that ball up and run with it. So they go and plug those patients in for primary care, or they help patients with gas cards or signing up for public transportation. They help patients with making Medicaid applications or hardship applications to the hospital system so that they can get charity care to write off charges that they might have had in the past. So as you can see, it's really critical to us, to make sure that our patients have the best of all, because that way, if we do diagnose a cancer on the other side, they have a much better likelihood of a positive outcome. Now, there are 15 members of our team, and Darcy's going to talk a little bit more specifically about our lung team as we move forward in the operation and logistics. But the primary team position is that cancer program development specialist. We have several RN program coordinators, and a PA that helps us with our screening programs that we run. We have high-risk prostate screening that we provide. We do, of course, the mobile lung cancer screening. We do mobile breast cancer screening. We have a colorectal cancer screening program called Fit for Life. And that Fit for Life program really kind of bridges them into sort of the prevention side of things. Any patient that completes that screening then gets connected to the YMCA in their local community for a three-month program there. So again, we really kind of focus on all aspects of what a patient might need for the long-term journey. And what you'll hear throughout the course of today is how important that is in building trust with the communities that we're serving. And that trust results in higher show-up rates for our screening programs. It also results in patients stepping forward when they may change in circumstance and something in their health doesn't look like it did when we first met them. And we're able to plug them in and navigate them for the care and resources that they need. So why did we start this program? Well, most of you probably know we're the tobacco belt. And when we really did a hard look at our communities, we found that many of our individuals started smoking at 6, 7, and 8 years old. It was very normal at that point. We are surrounded by tobacco farms, and it was part of the common culture on the tobacco farm. Several of our communities, Concord, in fact, was the location for the Philip Morris plant, and employees who worked a full week, their gift in addition to their paycheck was 2 cartons of cigarettes. So smoking rates remain tremendously high across our region. We also tend to see a lot of socioeconomic issues amongst our patient population, lots of uninsured patients. Of course, we're not a Medicaid expansion state. And all of these things really translate into, of course, poor health outcomes. We knew that we had made great strides in breast cancer screening through mobile mammography using this patient-centered approach. And so we kind of theorized after looking at our numbers and looking at the cigarette usage in our area that could we do the same thing in screening for lung cancer that we could in the breast cancer space. And so that really started our journey at that point of just having the conversation, does this even exist? You know, many of you probably faced the same situation back in 2015, you know, when we looked at our population, you know, more than half were coming at stage 4. So in many of our counties around the Charlotte area. So we knew we had to do something big and pretty quickly. So it started really with phone calls. Before we ever even formulated the first idea of this program, we had to decide, is there a unit out there? And after about 42 phone calls, I was fortunate enough to reach Camp Jenkins, who of course works with Samsung Neurologica. I had found information online about the mobile CT units, the mobile stroke units, and saw where they were having really great outcomes and figured if they have experience in that space, maybe they have experience in this space, or will at least have that early discussion with us. So I talked with Camp, and he was really excited about the idea, as Samsung had kind of been mulling over the same concept at that point. And he said, you know, I really feel like our team can do this. You know, we've had great success with the mobile stroke units. We really think that we can build you a vehicle. Of course, we had, and you'll hear from Darcy too, we had a lot of pushback at the beginning. We heard everything from, it's going to be too heavy. You'll never be able to get undisrupted imaging on a mobile unit. We heard it would cost too much money. We heard patients weren't going to want to come get screened. You name it. We heard all of it. But we just kind of kept going because we recognized that our patients really needed this level of care. We knew that we could really make a dent in that stage 4 number that we were seeing. And we knew that the patients that were at highest risk for this were out there. So we kept pushing forward with the idea. So we wrote a proposal for a program called Lung Basis for Life. And at that point, there really, again, wasn't anything nationwide that we could model it after. But what we did was we really pulled in the key components of what we do in breast screening. We were going to educate the patients about their risk factors, why this screening was important to them. But we also needed to educate the primary care providers. You know, I think we all know the NLST in 2011 really demonstrated the need for CT scanning to detect lung cancer early. But what we found was that many of our primary care providers were still relying on chest X-ray. So key to the program was really doing some robust education. Of course, step 2 of this program is really screening the patients, you know, taking that mobile unit out there and taking it on a frequency that makes sure they get those follow-up scans. But really key to the whole puzzle is that navigation piece, is navigating those patients to not only the community resources that they need, but really helping them to knock down the walls of the healthcare system. Oftentimes patients get screening results and they don't know what to do with it. They don't know who to go to. They don't know their next steps. And our team is really proactive with making sure they can get in for that first pulmonary visit. In fact, you know, Darcy will talk through some of her experience with pulmonologists where she's even been able to get those visits for free. Then, of course, our commitment as a safety net hospital is the intervention. And while patients are not required to have care through Atrium Health Levine Cancer Institute, we certainly make it available as needed. And we connect all of those patients with charity care, help with those Medicaid applications to offset the costs of that care. And again, really make sure that they are navigated very closely so that when they do begin treatment, they're assigned to that nurse navigator on the active treatment side. So our objectives for the program were really to improve the low dose screening rates across, you know, our urban and rural settings. At the point that we started the program in 2016, this didn't even exist. There was no screening through our hospital system for lung cancer. So we were really ahead of the curve in providing the uninsured and disparate populations a higher level of care early. We really wanted to increase participation in those low dose CT screenings for patients that we identified as high risk. We wanted to improve the cancer patient quality outcomes, finding that disease at an earlier, more treatable stage. You'll hear some of the results that we were able to accomplish that as we move through the talk today. We wanted to identify and eliminate those barriers. Again, patient-centered care for us is key, particularly with vulnerable populations. It's not enough to just screen and send on their way. We really have to make sure that they have the map clearly laid out before them. And then we really wanted to improve the lung cancer patient experience through streamlined integration into our healthcare system, so that they did not feel the stigma. They felt very connected along the way, and that we could deliver the best of care regardless of where that patient resides. So I'm going to pass this to Darcy at this point. I will say the Bristol Myers Squibb Foundation was our first source of funding. We did apply for they have several different philanthropic buckets. They've made it clear that they're no longer funding this because they've kind of pioneered it. They innovated and supported our program. But they gave us $1.6 million to develop the unit, to provide scans for 1,200 patients. And then key to the program is also that tobacco cessation therapy and nicotine replacement therapy. We want to make sure that, not only are we detecting cancer, but we're preventing that future recurrence. So Darcy will talk about our tobacco cessation program and how that operates within the logistics of what we do. So we wrote the grant in late 2015, received pretty quick approval on it. Somehow convinced Darcy to be crazy enough to join the team and start the program. And she really spent about 9 months educating primary care, just boots on the ground, knocking on doors, while Samsung constructed our first unit. So I am going to turn the reins over to Darcy and let her talk you through the program.
Hi all, James, thanks for the introduction, and thanks for letting Melissa and I share some information about this program. So as you can see on this slide, I was just thinking, as Melissa was mentioning the objectives and thinking about the original proposal to the Bristol Myers Squibb Foundation, it's insane to me how she wrote this proposal, came up with a vision, down to the navigation, the tobacco cessation, all the different layers that we truly are following through with exactly how the original proposal was written. I have not worked in a lot of grant-funded programming, but I just can't believe how insane it all matches up to what we do today. So I know the group that I'm talking to, and I know everybody knows the guidelines for lung cancer screening. So I won't even necessarily touch on that, but we are true to following that 55 to 77 year and 30 pack year smoking history. So we are currently screening uninsured, underinsured, and Medicaid. We also are slowly, not marketing it yet, but slowly opening up down to that 20 pack year smoking history as the USPSTF recommendations have recommended. I don't think our system will be opening up until obviously insurance starts covering and whatnot, but we have the capabilities of doing that at this time. So on the right, you'll see a picture of a screening. That is our original lung bus that was built in a partnership with Fraser-Built and Samsung, based out of Houston. And that is a screening in Anson County. It's one of the most, it's one of the toughest counties that we serve. There's a huge distrust of the healthcare system. And when we bring the mobile unit out to that area, we do break down some of those barriers, but it is and I'll touch back on the hardships that we face in some of these counties a little bit more later in the talk. So, and like you all know, patients are either currently smoking or have quit smoking within the last 15 years. We are at like a 90% of our patients that are still smoking. So, okay, let me go on here. So this is an inside picture of our original lung bus. So the patients come in, we have a stool that they get up on the table, and this is where they get their scan done. A majority of the work that we do on the unit is outside. So the elements are a huge part of what we deal with on a yearly basis. When we do interviews with our teammates, we ask them, are you okay with the elements? And everyone's like, yeah, I'm fine. And then in the nitty gritty of it all, people are falling out in that 100-degree heat. So, but yeah, the patients like that they're outside, they're not inside the truck as much. They feel comfortable. A lot of them are high anxiety, don't like small areas, even though this probably looks smaller than it feels when you get on it. But so programmatically, when we originally, before we even got the truck, as Melissa mentioned, I was going out and doing boots on the ground education in every community that we serve. I made individual partnerships with the clinics that I knew would be our highest referrers. So FQHCs, free clinics, sliding scale clinics. We partner with it used to be Gaston Family Health Services, and now is Contegra, is a huge FQHC that has like a 6-county catchment area, and they are our biggest referring source. And over 70% of the patients that we get referred are non-Atrium patients. So this is not necessarily serving the patient populations within our network. It is serving the greater Charlotte area, and we're in 18 counties now. We started out in our original 9 counties. Now we're up to 18 counties and well over 20 counties that we're getting our patients referred from, but we are having screenings in 18 counties. So this started with just a very slow rollout, 4 patients at our first screening in April 2017. And now we have 2 to 3 screening days a week, and we are deploying much more frequently. We had a little bit of a lull with COVID, obviously. And now, right now, we don't have any annual follow-ups due because of that, because we weren't doing any screenings at this time last year. But once this 3-month lull is over and we get back to July, when we started screening again last year, we are going to be just picking up significantly. So yeah, it started with the education piece, and then we slowly started rolling out the schedule. It was just me at the very beginning, staffing wise. So I was doing all the scheduling, I was doing all the networking, I was doing the screenings, and slowly over time we added more and more staff, and now we have myself, and I'm the supervisor of the program. We have 2 RN program coordinators, 2 cancer program development specialists, APP, and we also have a scheduling supervisor and a data coordinator. And so we have really grown in the last 5 years to get to where we are now. And it has not been without the roller coaster of emotions, that's for sure. And so moving on. So this is a picture of our new unit. So we do deploy both of them right now. When we have our schedule set for every 3 months in every county that we serve, and it's on a rotating basis. Our staff rotates covering screenings. We are now at the point where we're doing all of our documentation on site at the screening in real time. So patients have to get checked in and out through the radiology system. We do our navigation assessment, which Melissa alluded to that earlier. Once we verify patient information and sign their consent with them, we do a very robust navigation assessment where we're assessing, their level of schooling, their work history, and then, of course, resources that they need to be plugged into locally for food insecurities, housing insecurities, safety at home. And then we also ask about family history of cancer and get them into a genetic counseling. And then we, of course, refer them to our other free screenings. So if they have not had a colonoscopy, if they haven't had a mammogram, we'll do education about why that's important and then refer them on for that. We also have a very robust tobacco cessation program. I would be lying if I said that this literally was not as good of a focus at the beginning as it is now. We are really, the team that we have is all certified in tobacco cessation counseling now. So we do on-site tobacco cessation counseling, and we have developed a way, and I know a lot of you guys are like, there's no way we would ever be able to make this work. So this is a huge challenge, but I am telling you, if you can get the money and the resources to make this happen, it will improve your tobacco cessation success rate, your quit rate. So we do the counseling on site, and then right at that time, we come up with a plan with the patient, and we enter their prescriptions in. They are sent directly to our APP, Kia Dungan, and she approves them. And then within 48 hours, the patient receives their NRT at home, and they're way more likely to start it that close to when they're getting their screening done, because they're already kind of in it to win it with this idea of becoming more healthy. And then we do follow-up calls. Our team kind of spreads out the calls. They do a call 2 weeks out, and then every 3 weeks thereafter to supply refills, talk about behavioral modifications, kind of, get a good relationship going with the patient. And we are spending a lot of money on nicotine replacement. This is all written into the grant, but it is something that has really paid off on multiple levels. The relationship that we make with them on site then builds to better rate with the tobacco quit rate will go up, and it's all encompassing. So that is an exciting part of the program. And so looking at this chart compared to the other one, we were excited to bring this one on for multiple reasons. But for one, as you can see, there's 2 doors in the back. The first door is where the CT scanner is. So it's sitting right behind where the Levine Cancer Institute mobile screening unit. It's right in that compartment. And I'll show you some more pictures. The second area is where there's 2 pockets of seating areas. So we are opening up some research studies. We've opened up one, and we'll be opening up another one hopefully this year. But we can do blood draws back there. We can do informed consent, and it just gives us a little bit more freedom to be out of the elements. If COVID wasn't a thing, that sure would have helped, because then we get this nice new truck, and during a pandemic, and then we still can't sit inside. So, but it really has helped. So we right now have an under 55 clinical trial that we opened January 7th of 2021. We are screening patients 40 to 54 years of age with a 30-pack year smoking history, and we do a true informed consent with them. They get a total of 3 scans with this program with us. And so we're able to do the consent on the truck with it, which is less distracting for the patients and for us. So this is the inside. That is not a patient. That is one of our coworkers at Mobile Medicine. And he is just, a great model for us. And that is Brooke. She is one of our ARM program coordinators. She is going to murder me that I put this picture in the slideshow, but it's okay. We're not in the same room, so that helps. So this is our area right behind where you see the AED machine behind that door. That's the control area for the CT tech. So we do have a little sitting area in there, and then to the left of where they are is the cab of the RV. And so it's very open and airy, and then we have the compartments in the back. Excuse me. And so, another thing that a lot of people ask about with our program is, where do you park it? How did you figure all that out? And that was something at the very beginning I had no idea. I was like, crap, this truck's going to be delivered next week. It's going to be in my driveway, and I don't know how I'm going to keep it temperature controlled and all that. But then we made the connection with Mobile Medicine, and we are lucky enough to have them through Atrium Health. We pay them a monthly fee to take care of all the maintenance, make sure it's gassed, clean, everything with the truck. Electricity is going to it, it's temperature controlled, and then they provide us with a driver. All of our drivers are CDL licensed, and most of them have a EMT, paramedicine, firefighter background. And so it's just a really nice resource for us to have and have them on site. It has been very helpful when there's issues with the truck, or the trucks break down, which doesn't happen very often, or there's some issue that comes up. They're the ones that deal with that, and it doesn't necessarily have to go directly through me. And so Samsung's able to come on site to do the preventive maintenance on them and do everything, and we work really closely with them if there's any concerns that come up with the scanners, and they're really good at responding to that. So moving on. So here is the wonderful staff. We have our CT tech on the far right, and then Lauren Davis, our RM program coordinator, Brooke Weatherford, RM program coordinator, myself, I'm the short one. Then Kia, APP, then Stephanie White is the next one, and she's our cancer program development specialist. Bobby is our driver. Glenn is not in this picture. He is another cancer program development specialist. And then Jamie she's our scheduling coordinator. She kind of does all the behind the scenes stuff with making our phone calls, making sure, there's communication with the providers about if patients are scheduled or if they're missing an order. So something I am going to talk about right now is why our APP is so important to our program and how that has really allowed a lot of doors and opportunities to open that we didn't know were a barrier. So Kia joined the team, oh gosh, I don't remember, about 3 years ago, 2018. Yeah, shortly after we started screening patients, probably about a year after. But we started layering head and neck cancer screening and education into our program at that time. So Kia was doing that piece, and that was huge. The patients, there was a huge lack of education with head and neck cancer. And so we were able to start rolling that in. And probably one of the biggest programmatic changes that we made at that time was, instead of waiting for the providers to send us a follow-up order for the annual low-dose CT or even a 3-month, 6-month follow-up, we started having Kia write the orders for us. And you might think, oh, that's really not that big of a deal. Well, our follow-up rate increased significantly in that time. We are very proud that our number, and very boastful, I guess is the word. I brag about this to a lot of people, that our follow-up rate is over 60% for our patients. That is unheard of with most lung cancer screening patients or programs. And there's a number of reasons why that happens. And one of them is that we get these orders written by Kia. It really has broken down a lot of barriers and us waiting on orders. But the other one is the relationships that we make with these people. And that's through tobacco cessation. It's through the resources we offer. There's just so much opportunity for us to love on these people and have them come back to us for that care. Any of us, we have our annual primary care appointment or our dermatology visit or our mammogram, and we go and somebody is rude and nasty to us and we don't want to go back for it again. We're going to say, screw it, we're not doing that again next year. Not to say that's how it is for everybody. However, people want to come back. They're excited to come back to see us. We have one patient, he goes by Gator, and everybody on our whole team, all 15 of us, know who Gator is. But he will come back just at the location, even though he's had a cancer diagnosis, he's gotten his treatment, he's not going to get another lung cancer screening for a while, and he just comes to chat with us. So we just made that relationship, and it stuck, and he will call any of us whenever he wants. And we answer and we chat with him until he's done talking. So yeah, but really without the amazing staff that we have, then we wouldn't be able to, have the success rate with the follow-ups. So, I'll talk just a tiny bit about the CT tech. So we partner with 3 radiology groups that are all privately owned, not through our healthcare system. And that's so different in every area. But we contract to have a CT tech through one of the radiology groups. So it works out well, and they always have somebody available. They're all PRN, and that's just a side note about it. But they can then come back to the warehouse after the screening day and they transfer the images over. Then we have other folks that kind of help fix the expectation or the exceptions on the images, scan and paperwork, and then the reads get done usually within about 48 hours, 24 or 48 hours. So I'm going to talk to you guys just a little bit about the stigma and the just tobacco cessation, looking at the whole patient. So, you look at this, I think a lot of people look at this and they're like, oh my gosh, he couldn't even take his cigarettes out of his pocket before he got the scan done. And I look at this and I'm like, I love this man, and it looks like he needs a new pack because he's getting low. But, that we try never to, let our views of these people and what they've done to themselves or what position they put themselves in get in the way of the care that we provide. And I think that when you're I grew up in rural Kansas, literally in the middle of the United States, in the middle of nowhere. And the rural area that I grew up in is so different than the rural areas around North Carolina. These people do not care what you think about them. They don't care that they've smoked since they were 6. Some are upset with themselves and they know they need to do better, but some of these areas, this is truly cultural. Their family, the only way their family stayed alive and sustained as long as they did was because of tobacco. And so they would never look at it as a negative, even if they know that it's harming them. And, there's something truly amazing and refreshing about people that just really don't care about what you think. And at the same time, our job is to help them understand that this could be hurting them. And it's also for us just to support them when they need support. And so I think that has been one of the most truly eye-opening experiences for me with this position, is just meeting the patients and the community members where they need to be met. And a lot of our annual follow-ups come up. Last year, they didn't want to try quitting. Next year, they didn't want to try quitting. Third year, you know what? I'm going to do it this year. I think I can really do it. And that is amazing as well. So yeah, I just thought that this is one of those CT scans that you catch and you're like, oh my goodness, I can't believe we caught that. But he's a nice guy, and he's still coming back for follow-up. So this is one of our patients that we screened in Burke County. Ironically, that picture you saw before was a Burke County patient too. And this is Mr. Orders. He was our 1200th patient on the lung bus. And he was very, very appreciative of us getting this test done for him. He came straight from work, and the girls said that he just was above him. I mean, he's just over the moon with appreciation. And that's the thing, with this under 55 clinical trial that we're doing, the amount of just whole appreciation that people have, that they are really wanting to get super engaged in their care. A lot of these people have never seen a primary care doctor, and they come get the scan done. They want to quit smoking, and we get them plugged in with the primary care. So the impact that we're having on these folks, I think, is just, more and more awe-inspiring. Sometimes we get a little overwhelmed because we just keep layering more and more things into our program, more screening opportunities, more things we can provide to the patients. But it's so organic, the way that it unravels itself, that, we just can't, it's like we can't stop. So here, back to Anson County, that's the same picture. So one of the biggest things, like Melissa touched on, and I mentioned it a little bit, was community partnerships. So this is parked outside a federally qualified healthcare facility called ARMS in Anson County. And, they tried doing an event at the site the same day we were there, like a health fair. And it really did. I mean, we had about 12 people show up there, but then we haven't been able to follow up with those 12 people. And, it goes to the question of, are we doing a disservice by screening people if we know they're not going to get the follow-up care that they do? But now it's a lesson learned for us all, because we have put some different things in place to make sure that, the patients understand, and the staff and the providers understand how important the follow-up piece is. So this is just one example of kind of what it looks like at a screening day. Now we have 2 huge tents, 3 tables, obviously a PPE table, just a lot more robust setup. We've got charging stations for us to charge our computers, because we're doing all of our documentation in real time, and just making sure we get kind of everything buttoned up and taken care of for the patient as quickly as possible. And so the part that I have not touched on is positive diagnoses. So, a lot of people, like Melissa said at the beginning, the naysayers are gonna naysay, and they sure did. They just thought, there's no way, how are you going to get a PET paid for if it's negative? What if they're positive and they don't have insurance? All these questions. And I said, I'll figure it out. I've always figured it out. I'm a big girl, and I'll figure it out as I go along. And luckily I have. I did straight up go to the Atrium Health pulmonologist and say, there is no way anybody is going to pay up front for a pulmonary appointment with our program, and we don't have funding for it. So will you at least see just our lung bus patients for free for their initial visit? And every pulmonologist I talked to, they said, yes, we'll see them for that initial visit for free, which is amazing. That is a huge barrier. And for a lot of places. So how it works is once they get how it works now, and this is not how it always has worked in the past, but now we have a nodule tumor conference Wednesday at noon every week. So if a patient comes up with a lung RADS 4, we present them at tumor board, and the team of providers comes up with a plan. And then that gets reported back to their primary care. If the clinic needs assistance getting a PET set up, getting a pulmonary visit, we assist, the nurses on the team assist and get that taken care of for them. So, there's a lot of gray area with this. What if they go to their pulmonary visit and they have a PET and the PET's negative, and then they have, a $3,000 bill for this PET scan? And we have run into that. And I usually work to try to get internal funding or charity care, and we get them set up with their charity care paperwork. And it 100% has worked out 100% of the time. That is not for it being hard. It's always hard to take care of people that don't have enough money. And we all probably know that on this call. However, a lot of times we'll have to help with Medicaid paperwork getting filled out and figuring out the next steps. And we offer, the patients leave the screening with our cell phone numbers so that they know they can get a hold of us if they have questions or concerns or they're nervous about what the next steps are. So, and that is a couple of our staff members and one of our patients, Dawn. She was at the Anson County screening, and unfortunately, she was one of the patients we did do her annual follow-up, but since then she's been lost to follow-up. But she was really, really appreciative, and we got her plugged in for a free mammogram as well. And there is a picture of Kia doing a head and neck cancer screening in Anson County or in Stanley County. And, she goes through and just does a oral assessment and just a palpation of the neck and around the ears and everything, and then does education with the patients. And she looks so cute in her headlamp, doesn't she? Yeah, pre-COVID. Yes, pre-COVID. And this is, yes. Okay, so this is our last slide. I know everybody's like, oh gosh, when's this going to get over? Excuse me. Okay, so this is some of our data. We are embargoed right now on our 1200 data, and I will talk to you about that and kind of give you a little bit of information about where we're at to date. But as of 2019, we had screened 550 patients. The demographic breakdown that's written here is pretty true to where we're at now. About 20% African-American, 3% Hispanic, 70% or more rural. Uninsured, sitting right at 66 to 70%. Medicaid, 34, that's about right. And, Medicaid is covering lung cancer screening. But there's a lot of patients that still can't pay that $3 copay. And, we also layer in a lot of other services. So sometimes we just, like to go ahead and screen the Medicaid because there's usually a lot of disparities in that group anyway. Male to female ratio 1.1 to 1, and median age is still right at 61, 62. So in the original 550, which was published in The Oncologist by Dr. Raghavan last year, so we found 12 lung cancers. We are now at 30 lung cancers diagnosed. 6 were early stage, and now we're at 15 early stage. So half of our cancers are at early stage. Then we're at 38 lung RADs, 4, now we're at 97. Well, I'm getting a little overwhelmed just like thinking about this. Earlier identification could have a profound economic impact with a potential saving of $1.6 million per patient. And that number is overwhelming if you really think about it. Like, this is so dumb not to consider this cost savings wise. An update to be presented. Yes, Dr. Derek Raghavan, our leader here and the president of LCI, he submitted an abstract for ASCO 2021, and it got accepted for an oral presentation, which is really exciting for our team. We also have a poster presentation that will be The abstract was submitted by Dr. Daniel Carrizosa, and he's our medical director for our program. And that was accepted for a poster presentation. So the lung bus will be highlighted in 2 different presentations at ASCO this year. So that is all I got for you. I'm going to turn our camera on, and Melissa and I are together, and we will take any questions.
Yeah, so we had some questions submitted. First question comes from Mark Parker. Does North Carolina require a COPN certificate of patient procedure need for mobile screeners? If so,
Yes.
how do you get around that issue?
That's a great question. That was literally one of the worst meetings I think that I've ever had in my life, was when we talked through the CON process. And I'll actually tell you 2 scenarios that we've had, both North and South Carolina. So we are a certificate of need state, and that means that we, of course, would have had to go through an 18-month process and have a very specific map as to where the bus was going, not intruding or being, not trying to capitalize on service in an area where patients were being billed. Our system, when we initially said, hey, we got this money, we're building this bus, said, oh, I think you're going to have to go through that whole process. But when we really pushed back and started to look at it, we said, we're not billing patients. We're never going to bill patients. That's not what our program is intended to do. I know some of you on the call are probably looking at a profitable model, but we're here for the underserved. So our CON person with the system went back to the state and said, can we get a research exemption? This is literally just to provide supportive care to patients who otherwise would not get this level of care. And they gave us a research exemption as long as we agreed, again, not to bill the patients, which we would never do. Now, the second scenario came up when we talked about moving the bus into South Carolina, knowing that we have service area there and there are the same patients there that we're finding in North Carolina. We knew that we were over the threshold and we're potentially going to have to face that. Well, we had owned the first truck at that point for about 3 years. And think about it when you drive your Miata off the car lot, it depreciates within the first, 2 days. You're probably looking at 50% return on your investment. So we posed that question. We said, is this still at the threshold? Our purchase price was X, but now we've depreciated and this is what the value should be now. And they said, absolutely. So we were able to get an exemption there as well. So great question though, and really a challenge for a lot of people to think about.
The second question, and I want to make sure actually on this first question. So they said COPN, which is a patient procedure need. Is that also included in that?
Mm-hmm.
So the second question comes from Michael Geiske, and I think you actually spoke to this, Darcy, but any plans to expand to the 2013 or 2021 USPSTF criteria?
Mm-hmm. Yeah, and it's tricky because who knows how long it's going to take Medicare and private insurance companies to start covering that. I heard from somebody that Medicare is going to start by the end of the year, but I don't see that happening because Medicare doesn't do anything quickly. And so we just kind of decided we're not billing, and so it's not like we can get our hands slapped for that, or at least I hope I can. But yeah, we're going to just lower the 55 to 77 for sure. Our clinical trial, we're trying to see if the benefit outweighs the financial burden it would take on the clinical trial before we lower in that group. But we would have so many referrals for the under 55 clinical trial if we lowered that PAC year. And not that we don't have any issue with referrals right now anyway, but yeah, we're just kind of a little more hesitant with that.
This question comes from Prathamas Sturge, and it asked, have you used this setup for COVID low dose lung screening?
No. And I've talked to Samsung a couple of times about how they're doing that programmatically. There was talk of us kind of doing that early on, but they I don't know. I'm not sure why we never really pulled the trigger, but we really needed to focus on our lung cancer screening program too. And so no, we have not been using the truck for that.
We are adding vaccination, though, to the program. So when Darcy talked about layering things in, we know that this population of individuals are the least likely to get vaccinated, access, fear, et cetera. So knowing that we have that trust, the team is working now to establish a process to add vaccination for the patients.
Oh, that's amazing. Okay, so next question. How many scans do you do in a day? How do you transfer the data back to your PACS? Is the bus self-powered? I guess let's tackle the first two. So how many scans do you do in a day and how do you transfer the data back?
Okay, so scans in a day, we have pushed ourselves to 37, I think is the most we've ever done in a day. I'm surprised the scanner didn't blow up, but or the CT tech didn't walk away and be like, I'm done. But no, we've pushed ourselves, especially when we had a COVID exposure and we had to cancel because we didn't have staffing available. So we had to just clump somebody in one day. And it's like the only way programmatically we're going to figure out if we can do this is if we just do it. You know, you have in your head built up, oh, that's just going to be too much or it's not going to be enough or whatever. And luckily it wasn't like pouring down rain that day because we were busy. We had walk-ups, which we can accommodate for because we have our provider on site, which is great because we can just write an order there in real time. What was the second part of the question? Oh, about transfer of images. So we've been through a lot of different trial and errors with this. We were originally, when we partnered with mobile medicine, they didn't have a place for us to connect to the network connection to get the images transferred. So for a while, we were having to drive to a different location to transfer the images. And then we started using like an external hard drive, like a robust flash drive. We transfer the images there to a secure location, then we bring it back. And now we have a good setup where at the warehouse where we park the trucks, there's a network connection box. You can just hook the cable up and then send the images directly into PACS that way. So once the images get into PACS, then we have to have somebody on the back end fix the exceptions because it's not showing up into our system the same way it normally would if you did all this in real time. And then it gets dispersed appropriately to the correct radiology groups depending on what county we're screening. So that I know is clear as mud. But you can reach out to me if you have any questions.
Okay. Okay, the next one is the bus self-powered or do you need power at the scan location, like a shore power?
No, you do not need shore power. It's run on the generator. We did have a little bit of, so we have and I should know what kind of generator that we have on each of the trucks, but we've never had an issue with power as long as there's enough gas in the tank of on both trucks, we're fine. And there was a little bit of issue with weight on our newer vehicle. Part of that, and they got that all figured out, but that's another thing to consider is the amount of weight that they're putting on because it won't be able to, once you add supplies and drivers and everything, it's something that you have to deal with when you develop a truck, I guess. I'm learning a lot. I'm a nurse that knows a lot about mobile units now, so not something I would have envisioned for myself.
The next one is just a comment. It says, this really touches on all the points wanted to bring to the group, begins to address the issues on our list, and they're looking forward to great follow-up. Next one says, congratulations on a very innovative program. I've been monitoring it from afar, and I'm very pleased to learn more about it. This question here says, by the way, with the smaller vehicle, it looks like that was the initial undertaking prior to the Winnebago build. Did that not work out logistically at the time, or is it just that Winnebago provides better space?
Yeah, we use both. We really, it was an opportunity that we got to partner with both groups, and we were like, yes, we had really no opinion about which one was better suited for the team, except for the research side. When we start opening up, our under 55 clinical trial, and then we're considering opening up a research study surrounding firefighters. or running through more programs and more blood draws or blood pressure checks or any other of the layering. But honestly, we could do any of that in both of the vehicles. So there is really no preference, and we do deploy both of them. As we amp up, I think it'll be, both deployed at the same time even. But that's a good question. It does seem strange that we have two different trucks, but no, one's not the redheaded stepchild, I promise.
Okay, this one says, would you mind forwarding your clever template for the COPN workaround, Mark Parker?
Yeah, I can see if I can get a hold of that from our person that developed that process. Yeah.
Next question. As per your experience, will this be an ideal setup for low-dose lung screening as required for India scenarios currently?
India scenarios.
Can you say that again, James? I don't know that we quite heard that whole.
Yeah, I'm not quite sure. Maybe it needs to be rephrased if Prathmesh is still on.
Is that
Has the team written this process into a model with all the steps outlined, the stakeholders involved, et cetera? Other nonprofits and health systems.
That's a good question. If you're willing to pay me, I'll write it.
I think we've been so busy with sort of building, launching, and then seeing if it was going to be a success. And we're kind of now at that point where we know it's an effective, model of care. We know that it's working. We know that it's detecting cancers early. So, I think we've done a good job of documenting along the way. It'll just be a matter of Darcy and I sitting down and kind of pushing those pieces all together so that someone else that might want to start a program like this could look at it from the same lens. So, but it's a great question, and there's definitely a ton of layers to it and a ton of things to think about. But I will say the important thing too for us in programming is to not think too hard about it, because if you think of all the ways that it can't be successful, then it won't. Mm-hmm. A lot of how we operate is we kind of throw some things at the wall and see if it sticks. We don't take no for an answer a lot of the time, actually most of the time. My husband will tell you that. But it's really important to us to not get what we call analysis paralysis and have meetings around changes. A lot of times we just innovate and then we tweak the process along the way. And that's really been key to our success in all of our programming.
Good. I think 2 more questions here. You expanded to head and neck screening. Was that for smokeless tobacco screening, or what standalone for H&N metastatic disease in known patients?
No, this was just purely education and outreach for the, knowing the smoking and drinking association with head and neck cancer. And a lot of people didn't even know that was a concern. A lot of the patients, a majority of the patients, didn't know that head and neck cancer was a concern if you were a smoker or hadn't even heard of that as being a thing. And so, and we, ironically, with the head and neck cancer screening, have found they will ask Kia, like, will you look at the spot on my cheek or on my forehead or on the back of my head? And she has actually diagnosed a handful of skin cancers that way. And so, but no, this is not specific to head and neck cancer patients at all. This is purely just the education and outreach, like on the screening day site, on site with the screening day.
And we do have separate standalone events for other high-risk populations. For example, we have a firefighter first responder program here with education and then follow-up screening. And we do head and neck screening with that group, knowing their prevalence for that kind of cancer.
So I think I've determined this last question is as per your experience that you've had with these vehicles, would this be an ideal setup for a country such as India for lung screening, which also does have quite a high population of smokers and kind of needs that type of outreach as well, where it's mobile and needs to be able to get around?
I really think, to be honest with you, it's ideal for anywhere, particularly if you have a large volume of high-risk patients. But think about it, you know, why is Netflix successful? Why is Amazon Prime at my house every 2 to 3 days, or every day, to be honest? It's because we all like the convenience and we all like the comfort of being in our own territory, our own area. And you're much more likely to take advantage of something that is somewhere you already are, and you can get in and out, and it's not overwhelming. You don't have to learn how to navigate a medical campus. You don't have to find a place to park. It's a very simplified process. So I really think ideally mobile is kind of the future of the way that we're going with all care, I think, across the spectrum. We're even, you know, considering adding a lot more of our screening services on site same day. Because again, if you've got access to these people, the chance of pulling them back for, you know, 2 or 3 other screenings is highly unlikely. So yeah, I definitely think that the model itself, we're going to see this continue to perpetuate and grow.
Okay, so that will wrap up our webinar. Darcy, Melissa, thank you so much for your time. Thank you for your wonderful program and presentation. Thank you everybody for attending, and we hope to see you all soon.
Thanks, James.
Thank you.
Appreciate it. Thank you, everybody.